everyone. Welcome to another Expert Talk series, coming right to your living room. These are the kind of things that we want to share because we know how far you are apart sometimes from a clinic, and so we want to bring our specialist right to your door. And for all of you who see this on YouTube, if you could subscribe to our channel, then you would get these programs every time that they come out, right on schedule. So once again, thank you all for joining us tonight. And over to you, Christian.
Thanks, McFinn. And so I'm happy at this point to introduce tonight's speaker, Dr. Mark Garret. Dr. Garret is an ALS physician and researcher at the Sean M. Healy Center for ALS at Massachusetts General Hospital. And he received his medical degree from the University of Pennsylvania, followed by a neurology residency and neuromuscular fellowship at Washington University in St. Louis. His research focuses on genetic forms of ALS and improving understanding of presymptomatic disease states in ALS. And he runs the Dominantly Inherited ALS Network, or DIALS, a research study following asymptomatic carriers of ALS, gene mutations at MGH, and other studies exploring biomarkers to improve early detection of ALS. So Dr. Garret, thank you so much for joining us, and we're turning it over to you now.
Sounds great. Thank you so much for the introduction, Christian. So I was really going to focus most of my talk today on some of the genetics of ALS and really looking at how we can kind of learn from the recent progress that we've made in familial ALS and FTD, and really trying to leverage that towards, the ultimate goal of preventing ALS altogether. So just to kind of briefly review, some of the nomenclature with this, with ALS, one of the first questions I often get in clinic is ALS inherited? And so, we've for many years used a term called familial ALS to denote people who have who have ALS and have a history of close family members who've been previously diagnosed with ALS or other related diseases, including frontotemporal dementia. And in total, these patients represent about 10% of the total number of ALS patients. However, we actually know that when detailed genetic testing is performed, about 5% of sporadic ALS patients who have no known family history of ALS turn out to have an underlying genetic cause. So in total, about 15% of patients with ALS, it turns out, have this disease due to mutations in a single gene. And so because of this, 5% of ALS or of sporadic ALS patients having a genetic cause, I really prefer the term genetic ALS to familial ALS. To kind of go back a little bit to the basics of genetics, we know that most gene mutations that cause ALS are inherited in what's called an autosomal dominant fashion. So we all have 2 copies of each gene in our body, one that we get from our mother and one that we get from our father. And in the case of these autosomal dominantly inherited genes, having a single copy of an abnormal gene from either parent is enough to cause disease. So when someone who has a genetic form of ALS and carries one of these disease-causing copies, has a child, we know that child has a 50% chance of inheriting that disease-causing gene themselves and a 50% chance of inheriting the normal gene. And unlike some other, types of diseases, there's no effect of sex on transmission. So mothers can pass these genes on just as easily to their male children as to their female children, and vice versa. So the first genetic cause was discovered back in 1993 when Bob Brown discovered a gene mutation called SOD1. For a long time before that, we'd known that there were families that seemed to develop ALS, but we didn't quite know why. Following that initial discovery, there was a long period without any new ALS gene discoveries. But over the last 15 years, we've made huge progress in terms of our understanding of the underlying genetics of this disease, with the biggest of these being back in 2011, when we discovered a gene called C9orf72 that turns out is the most common genetic cause of ALS, as well as the most common genetic cause of FTD, or frontotemporal dementia. We now know that there are over 20 different genes that are definitively shown to cause ALS, and over 40 that are associated with an increased risk of ALS in total. So looking at some of these kind of common genetic forms of ALS, the most common one worldwide is this hexanucleotide repeat expansion in a gene called C9orf72. So patients who are affected by C9orf72 mutations may develop either ALS, dementia, particularly this form called FTD, or sometimes both. And what's interesting is that within families, some people will have ALS, some will have dementia, and some will have both. And it's very challenging or impossible to predict who may be at risk for one or the other. In total, about 5 to 7% of ALS patients carry the C9orf72 gene. And patients who have ALS due to this gene mutation are typically indistinguishable from sporadic ALS patients who you see in clinic, with a very similar age of onset, typically, or with the most commonly presenting in the late 50s. Looking at some of the other common genetic forms of ALS, the second most common one is what's called the superoxide dismutase 1, or SOD1 gene mutation. This is about 2% of total ALS. And unlike C9, this is not typically associated with frontotemporal dementia. One of the interesting things is that there are lots of different changes in the SOD1 gene that can all cause disease. And some of these are known to be associated with very rapid progression, whereas others are known to be associated with much slower progression. The last individual gene that I'll kind of bring up is a gene called FUS, or fusion sarcoma. This is the fourth most common genetic cause and represents less than 1% of the total form of ALS. However, this is unique in that there are some changes or some FUS gene mutations that are associated with a very early age of onset that can affect even teenagers or people in their early 20s. These are often known to have very rapid disease progression. However, I'll say that understanding the genetics of ALS is not just relevant to people who have a strong family history of ALS. So in sporadic disease, we often are unable to determine exactly why someone develops ALS. However, we're increasingly learning that genetic changes may also play a role even in these people without family histories of disease. And that's because there are many additional genes that may affect someone's risk of ALS to a much smaller degree than C9 or SOD1. And these changes may not be sufficient to cause ALS on their own, but if you combine them with other risks like head trauma or military service that have been shown to increase someone's risk of ALS, may be sufficient to cause ALS in that individual. This may be part of what we refer to as the gene-environment interaction. I've listed just a couple of those modifier genes, like the ataxin-2 gene, as well as the UNC13A gene, but there are many of these. In addition to increasing someone's lifetime risk of developing ALS, it's also possible that these genes may also affect other aspects of the disease. For example, their rate of disease progression, the age at which it onsets, or potentially where in the body the symptoms of ALS start. So people who have this particular change in UNC13A, called the RS12608932 polymorphism, have been shown to have a higher likelihood of developing bulbar onset disease. They typically associate with shorter survival, as well as an increased likelihood of developing frontotemporal dementia. This same change may even alter the efficacy of medications for ALS. So for example, there was a clinical trial that showed that patients with this change in UNC13A had improved survival when treated with a drug called lithium carbonate. One of the most important concepts, though, in genetics is something called penetrance. So penetrance is the likelihood that a particular change in a gene causes disease. So for people who have a disease-causing change in the SOD1 gene, about 90% of these individuals will one day develop ALS. It's notable, however, that that's not every single person who carries an SOD1 gene. Some of these people live to a very old age and never develop symptoms. For people carrying the C9orf72 expansion, this is still kind of a very high risk lifetime of developing either ALS or FTD. While it's difficult to estimate the exact number, this is probably between 60 to 90% of people who survive to age 80 will eventually develop one of these two diseases. For people with some of these risk modifier genes, however, this number is much lower. So people with what's called the intermediate length expansion in ataxin-2 have a risk of ALS that's approximately 3 to 4 times the baseline risk of ALS in the general population. And this means that they might have a 1 to 2% chance of developing ALS over the course of their lifetime. For people with the UNC13A variant, this number is even lower. And this means that even though many people may have these risk variants, for most people who have them, they'll never develop ALS over the course of their life. However, I do think that understanding how these different genetic changes have different implications on the risk of developing ALS, is really critical in counseling patients about genetic testing results. One of the most exciting aspects, however, of studying the impact of genetics in ALS is that this is really important therapeutic implications, and particularly because when we know the exact gene that causes disease, we can design medications that really get to the root cause of ALS. So to kind of go back to high school biology, we know that your genes or DNA are really kind of the blueprint for your body, and this DNA is eventually turned into RNA, which is then made into proteins. And these proteins form the building blocks for your body, including the cells of your brain and spinal cord. So when someone has a genetic alteration, that same alteration gets passed down to the RNA and eventually into the protein and leads to an abnormal protein that may cause disease. And so in many cases in treating genetic forms of ALS, we may be interested in lowering levels of a specific RNA or specific protein that causes disease in that individual in particular. So while there are a variety of tools by which we can do this, one of the most exciting ones recently has been a type of medication called antisense oligonucleotides, or ASOs. ASOs are really small segments of single-stranded DNA that are designed to bind to a specific RNA sequence. So for example, for someone who has an SOD1 gene mutation that causes disease, we could design an ASO that binds directly to the SOD1 RNA. This ASO is injected then into spinal fluid via a lumbar puncture or spinal tap. And the ASO is able to kind of go into the brain and spinal cord, bind to that RNA, and eventually that leads to the RNA being degraded by the cells. Ultimately, this means that there's fewer levels of the toxic SOD1 protein that causes disease. Another really promising strategy to achieve a similar goal is something called gene therapy or gene editing. In this case, rather than affecting the RNA, we would be potentially directly acting at someone's DNA to help kind of edit or change their DNA. All of these techniques, however, really allow us to, again, specifically target the root cause of disease, and we expect that this technique will allow therapies to be more effective in the future. What's particularly exciting is to some extent, the first wave of these medications is already here. So as many as you may know, Qalsody or Tofersen was recently approved by the FDA back in April of 2023. And this was the first therapy for a genetic form of ALS to be approved. Notably, this is only available for 1 to 2% of ALS patients who have mutations caused by the SOD1 gene. And this medication is delivered via spinal fluid injections, typically on a monthly basis. The way it works, as I stated before, is really that it lowers the SOD1 RNA and then eventually the SOD1 protein levels over time. And it's those proteins that cause toxicity and nerve damage in SOD1 ALS. So I just wanted to briefly kind of look at the results of that clinical trial. You kind of see one of the graphs from the trial that ultimately led to its approval. In that trial, we see that patients who initially started on Tofersen are in red. People who initially started on the placebo are in blue. And that over the course of a year of treatment, people who started initially on the Tofersen essentially had a sustained improvement in the rate of change on the ALS functional rating scale that we use to monitor ALS disease progression. We saw similar results when we're looking at respiratory muscle strength as well as motor strength as measured by something called handheld dynamometry, where we see that over time, people don't seem to be losing less function and that there's a sustained improvement in people who started that treatment 6 months earlier in the initial trial compared to people who started initially on placebo and then switched over to Tofersen, which is the blue group again. As we're kind of getting further and further out from that trial, we're now seeing that the patients who started earlier on Tofersen are also surviving longer, and that this difference is now measured in years rather than in months, which is really encouraging. One of the other key pieces of evidence that led us to know that there was a benefit of Tofersen is something called neurofilament light chain. So neurofilaments are structural proteins in neurons, and we can detect these neurofilament levels in blood as well as in spinal fluid in patients who have ALS, where they're highly elevated because there's rapid nerve injury that's occurring. So we also know that patients with ALS who have higher neurofilament levels have more rapid disease progression. And so as a result, this has really emerged as a very key biomarker in many clinical trials for ALS. And what we saw in the clinical trial, and what really led to the approval of this drug, is that there was a very large reduction in this neurofilament light chain. And in patients who were treated with Qalsody, this level dropped by about 50% in people treated by the drug or with the drug, compared to a small rise in people who were treated with placebo. And I think this is because the neurofilament light chain pretty directly is reflective of the rate of nerve injury that is occurring. And so lowering this is obviously a good thing. So in addition to Tofersen or Qalsody, we're also seeing promising work right now with another antisense oligonucleotide for the FUS gene and people who have FUS ALS. And so while there's now an ongoing phase 1 to phase 3 clinical trial of this medication called ulefnersen, which is a FUS antisense oligonucleotide. And there's been a little bit published on this, but on the left you can see actually a picture of J.C. Hermstead, who was a young woman who had a juvenile onset form of FUS ALS, who was the first patient treated with this medication. And this is kind of a graph of her function over time that was presented in a paper. And while she initially had experienced very rapid disease progression prior to starting on the medication, she really had pretty significant stabilization over time after starting on this treatment. Unfortunately, JC ultimately did die from disease, but I think really provided a lot of promise that this medication may be effective in the future. And we're very optimistic, I think, about the results of that ongoing clinical trial. So in addition to kind of SOD1 and FUS, we've also seen ASOs tried in C9, ALS and frontotemporal dementia, which unfortunately did not show any benefit. But I think more of these trials are coming. And pharmaceutical companies are now looking also at doing early stage clinical trials for actually sporadic ALS using these antisense oligonucleotides, in many cases targeting some of these risk modifier genes. And so I think this technology is broadly applicable to all with ALS. One of the things I'm most passionate, however, about is trying to see, could we push treatment earlier on in disease when I think it may be more efficacious? And the reason why I include this picture of the fire extinguisher is because I think about ALS a little bit as a metaphor of kind of a house fire. So ideally, you want to intervene when a fire is very small, when it can be put out easily by a fire extinguisher, rather than waiting until the house is engulfed in flames. I think intervening right at the earliest signs of disease is likely to have the very best outcomes. So I think to help really answer these questions, one of the key ways that we've been able to try to really examine the earliest signs of disease has been to really try to identify who is most at risk for ALS. And this is really the family members of people who have these genetic forms of ALS and FTD. In these individuals, genetic testing can be performed actually prior to the onset of symptoms to identify those at risk. And ultimately, following these gene carriers over time very closely can help teach us a lot about ALS disease biology, as well as help us kind of determine what are the best possible diagnostic tests to help catch this at the earliest stages for both people who have genetic forms of ALS, but these could also teach us about how could we diagnose sporadic ALS at earlier stages. So one of the ways we've kind of helped examine these is there are now multiple research studies that kind of evaluate these and enroll these family members of people who have genetic ALS and follow them over time. And so I work with the kind of dominantly inherited ALS network, or DIAL study, which is a study that is at Massachusetts General Hospital in Boston and Washington University in St. Louis. And we are working very closely with a similar study called the ALS Families Project at Columbia and have really been working on merging our two studies to form something called Prevent ALS. And you can see those sites in the red stars. So across the Prevent ALS study, we're now following a lot of individuals. And so we've performed genetic testing and worked with almost 500 people now who have come from genetic ALS families, with more than half of those people testing positive. Unsurprisingly, the majority of these individuals are positive for the C9 gene mutation, although we've seen people with multiple rare variants as well. All of these studies have the ability to kind of participate and just help us with research without learning someone's genetic status, in which case they're referred to as non-disclosure. And really the growth of these studies has really accelerated over the last couple of years. In all of these, so as I said, the principal goal of the Prevent ALS study is to follow these gene carriers over time and look at multiple tools that could be potentially used to diagnose and follow ALS in its earliest stages. This really includes blood and spinal fluid collection every 6 months to every year, detailed cognitive assessments, quantitative strength testing, and physical and neurologic examinations by neurologists. Some of these studies have also done regular EMGs and nerve conduction studies. We've also looked very closely, and I've actually worked with Univar at Everything ALS on projects looking at potential digital monitoring with either accelerometry-based wearable devices that could look for changes in someone's movement, or potentially we could use phone-based applications to try to monitor for changes in either cognition or in motor strength. And so I think we're still looking at what is the best way to monitor ALS gene carriers, but I think it's an exciting time, and we're looking forward to the translation of these into the clinical realm very soon. Some of the most exciting findings that have been discovered from some of these studies so far are the use of kind of blood or spinal fluid based biomarkers that may detect early or prodromal ALS. So by far the most developed to date has been something called neurofilament light chain, which, as I mentioned, is a marker of nerve injury that's highly elevated in ALS. And Dr. Michael Benatar, with the PreFal study at the University of Miami, really put together some seminal work about 5 or 6 years ago that showed that in SOD1 gene carriers, that you could detect elevations in the neurofilament light chain about 6 to 12 months before someone developed ALS. And you can see that graph kind of off on the left side. Recently, we've also been looking at other techniques. Neurofilament is a great marker. One drawback of it is that it may not be specific for ALS. Neurofilaments are elevated in many causes of nerve injury. So one of the markers that multiple groups have been interested in is something called cryptic exons, or basically looking for alterations in kind of RNA that are caused by changes in a really key protein in ALS and FTD called TDP43. And working in collaboration with Dr. Phil Wong's group at Johns Hopkins University, our group and some others show that we could actually detect one of these markers called cryptic exons in people who have sporadic ALS, people who have symptomatic ALS, as well as actually in C9 gene carriers before the onset of symptoms. So one of the key things that we're looking for is how can we predict exactly when someone who's at risk may get ALS? And so far, this NFL elevation or neurofilament light chain elevation has been the most important. Because this seems to elevate 6 to 12 months before disease onset, this may be a really key or critical window to intervene before people suffer significant nerve loss that may not be recoverable. One of the most exciting advances in the field to me has been an ongoing trial called the ATLAS trial. This trial enrolls asymptomatic carriers of SOD1 gene mutations. And it basically has the goal of trying to see, could treatment with Tofersen or Qalsody result in a delay in the time to develop ALS in these individuals? So people coming from SOD1 gene families can enroll in the study, undergo genetic counseling, and then genetic testing as part of the study. They're evaluated for any evidence of ALS at the time that they enroll in the study. And a serum neurofilament light chain is checked as well. And patients have to have no evidence of ALS and a low serum neurofilament light chain at the time they enroll in the study to start. Patients are initially followed, not followed with monthly neurofilament light chain levels. And it's only once the neurofilament light chain levels start to increase in a way that suggests that they're likely to develop ALS in the near future that they are then treated with either Tofersen or placebo. And the goal of the study at the end is to try to see what percentage of individuals who are treated with Tofersen develop ALS at the end of 2 years of treatment compared to the number who develop ALS on placebo. The hope would be that people treated with Tofersen are less likely to develop ALS at the end of 2 years. Obviously, interventions that only target SOD1 are not ideal. And so we really are looking forward to a future in which we can hopefully have preventative trials for carriers of C9 or 72 or other ALS gene variants. Of course, we need to really balance the potential benefit against any risk of intervention. So in many cases, the ideal candidates for this at this time may be lower risk interventions that could have possibility of benefit. So this could include things like low risk nutritional supplements, Riluzole, like is taken for symptomatic patients with ALS, or potentially diet and lifestyle interventions. And I think it remains an open question about which of these may be effective in pushing back how long it may take for someone to develop disease. So looking a little bit at just kind of recommendations for people who are in the audience and maybe thinking about, I have ALS, should I get genetic testing? I think one of the most important things to know is that, it's really important now that every patient with ALS at least be offered genetic testing by their physician. Doesn't mean that everyone has to get it, but testing panels are now available freely to patients through sponsored testing programs. And as we discussed, this information may change what medication someone is treated with and the clinical trials that are available to them. It also does help provide information to family members about their personal risk of ALS and FTD. And even if you don't have a family history of ALS, that doesn't necessarily rule out the possibility of a genetic disease. A different group of individuals who I think have slightly different needs are those who are genetically at risk. So the family members of people with genetic forms of ALS. And oftentimes people are wondering, should I be tested for these mutations before I have disease? And I think it's very important to say there's not one right answer for everyone. Some of the main options would be that people can pursue clinical genetic testing, where the testing is kind of is ordered by a physician and is put in your medical record. I generally recommend that everybody considering this first undergo pre-test genetic counseling with a genetic counselor, or at the very least, a knowledgeable neurologist. Even for ALS gene carriers, the sponsored testing panels are freely available and should not be a barrier. You shouldn't be paying for this testing. It is important to know that there can be insurance implications for patients for people considering getting this sort of testing to learn about a future risk of ALS. And it's also important to note that learning whether you're positive for a gene mutation that will one day cause ALS, or that you're negative for it, can have really significant psychological impacts for an individual. And so it's really best to do this in conjunction with a trusted medical provider. All of this testing can help guide follow-up options, whether you should follow with a neurologist regularly. It can also sometimes be helpful for family planning decisions for individuals who are thinking about having children in the future. There are now a wide variety of options as well for research-based testing. And sometimes this can be useful in keeping genetic testing results out of the clinical medical record. It can also ensure that you're regularly followed by a knowledgeable ALS neurologist. So some of the options for individuals who may be genetically at risk are the DIAL study at Mass General and WashU, the ALS Families Project at Columbia University in New York, as well as the PREFAL study at the University of Miami. For people who have C9 or 72 mutations or other genes that may cause either ALS or FTD, there's also a national study called the All FTD study, which does great work evaluating changes in cognition and MRI studies over time to help us learn more about frontotemporal dementia. And lastly, I'll say, for people who have SOD1 gene mutations, I do think the ATLAS study is a really wonderful opportunity to be monitored and potentially get medications that may affect the course of this terrible disease. Lastly, our group is in the midst right now of launching a very large observational study that is sponsored by the NIH, which will be at 34 sites nationally and will include long-term follow-up for people who are genetically at risk of ALS. So this is kind of showing all of the different national sites that will be under the All ALS study. And there will be different options for people who have symptomatic ALS to participate in this, people who are healthy individuals without neurologic disease, as well as asymptomatic persons who are at genetic risk of ALS, with the option for genetic testing to be performed through this study. So overall, we're very excited about the possibility of kind of bringing the work that we've been doing in the Prevent study to a national scale to hopefully increase access for people all throughout the country who are affected by this disease. So with that, I will kind of break and see if we can answer any questions.
As Andy said, thank you, Mark, so much for presenting today. And I'll take our first question here, which is, what are your thoughts on TAR-DBP? It seems to be the third in line for cause. One of our members in the audience mentioned that that their family has this defect. Could you speak more to it?
Yeah, absolutely. So the TAR-DP gene encodes a protein called TDP43. TDP43, incidentally, is a really key protein that is found to be abnormal in almost everybody who has both either sporadic or genetic forms of ALS and dementia. So TAR-DP can either cause ALS or dementia. It's a little less common. There are groups that are trying to work on different treatments for TAR-DP. And so I know Neil Schneider at Columbia University in particular has been trying to develop kind of antisense oligonucleotides for that gene mutation. I think, for people who are from TAR-DP families, I think one of the best options to kind of connect and figure out what the latest state of affairs would be potentially to connect with, some of the ALS gene carrier studies that I mentioned. So DIALS, the ALS Families Project, or PREFALS, and we can kind of help direct people to the best places. For now, there's not an FDA-approved therapy for the people who have ALS due to that gene mutation. And we typically would recommend that people be treated with the standard of care ALS drugs that are available to everyone.
Thank you. Martha's got the next one.
Yes, thank you, Dr. Garret. So we had a question on what are your thoughts regarding the penetrance of the C9 gene? Is it estimated at least that it's at less than 30%, and odds ratios of 15 correspond to what percentage of the lifetime risk?
Hard to do math on the fly. What I would say is that, so we really did used to think that the penetrance of C9 was higher than it probably is. So people used to say that the penetrance, if people live to age 80, that almost 100% of people eventually developed either ALS or FTD. As time has gone on and genetic testing is more routinely performed, we're seeing more and more people who are in their 70s and 80s who don't have evidence of, ALS or FTD. And so as a result, those estimates for penetrance have gone down a little bit. I know a lot of people have been asking about, there was a recent paper published in December of 2023 that was talking about penetrance of C9 ALS in particular, and was talking about within families it may be somewhat variable, but it gave estimates of ALS penetrance at around 20 to 25%. Mm-hmm. It's important to to make sure that we realize that wasn't including frontotemporal dementia. And so I think once you start including the risk of FTD, most estimates are at least above 50%, and I would say 60 to 90% is still where I see most studies coming in.
Thank you.
Dr. Garret. We've got some questions and comments regarding the ASO section of your presentation. Any comments on ASO trials failing in Huntington's that might be pertinent to ALS, or any lessons learned there?
Yeah, I think it's a great question. I have to say I haven't followed the Huntington's literature perfectly. And I will say that, ASOs, I think, are a very useful tool. They have a couple, major advantages. So one is they can be very specifically targeted to a particular, gene of interest. The second thing is that we can use them to bypass the blood-brain barrier by injecting them directly into the spinal fluid. However, we still, the antisense oligonucleotide still needs to have a desired effect. And it depends on, exactly how you're designing that medication. So, for example, in C9 ALS, we've seen 2 failed trials of antisense oligonucleotides. And that was obviously tremendously disappointing to the field, because I think there was a lot of optimism about those 2 trials in particular. One of the things that's challenging in, say, C9 is the disease biology is complex. It's not in SOD1, there's an abnormal, RNA and an abnormal protein, and it's the protein that likely causes disease through something called toxic gain of function. In C9, there's likely multiple mechanisms of injury. So there's probably toxicity from expanded mRNA segments, toxicity from something called dipeptide repeat proteins that are made from that expanded RNA. And there may be also some effect of loss of function of the normal C9 gene, although that's likely a smaller percentage. One of the things we found is those early C9 antisense oligonucleotides actually targeted something called the sense-stranded RNA, but left the antisense stranded RNA likely alone. And so now people are going back to the drawing board and trying to see how can we more intelligently design these ASOs to affect what we think are maybe more important mechanisms of disease. And so I would guess that the Huntington story might be similar, that we just don't have a full understanding of the disease biology, and we may need to more intelligently kind of target these ASOs.
Thank you for that. As a follow-on question to that, you mentioned specifically gain of function versus loss of function mutations, so given that they've targeted gain of function mutations for the most part, what are good tools for loss of function mutations or loss of function in general in ALS?
Yeah, it's a great question. So I'll say that first, that most ALS mutations are gain of function, which is why I kind of referred to those primarily. ASOs can be used to affect some loss of function mutations. So one of the examples from another neurologic disease is spinal muscular atrophy, which is kind of caused by a loss of function mutation in a gene called SMN1. And basically in the first medication approved for that disease, which has had amazing effects, basically targeted the essentially splicing abnormalities, kind of how mRNA is processed, and then eventually made into a final copy. And in that disease, it's that splicing that's really abnormal, and it affects the ultimate protein function. And so they were basically able to have essentially an ASO that's designed not to degrade the RNA, but to block a particular, say, splicing site on that. And it did enough essentially to restore the normal function of that protein and treat the loss of function. And so again, that is theoretically possible in ALS as well. I know one of the keys has been in TDP43, to kind of get back to that, there's likely components of both TDP43 loss of function and gain of function in ALS. The problem is it's really hard to just decrease the levels of TDP43, and that's because it's a really important protein that regulates hundreds of different mRNA species. And so one of the techniques that groups have, and drug companies have taken is to try to see, could you target instead some of the downstream pathways below TDP43? And so there are antisense oligonucleotide trials that target Stathmin-2 or UNC13A that are genes that are regulated by TDP43. And that's how they're trying to target loss of function of TDP43 in that case.
Great. Thank you so much.
Thank you, Dr. Garret. This one has to do with bulbar ALS in particular. We've got some questions regarding any clinical trial links that you can share regarding trials for bulbar ALS?
So let me just think. So what I say, I don't know off the top of my head too many. One thing that has been shown in a couple of recent kind of smaller studies has been that Nuedexta, or dextromethorphan quinidine, which it was approved by the FDA for the treatment of pseudobulbar affect, which is commonly seen in ALS, has been shown to have some efficacy in speech, in improving speech and swallowing function in people who have dysarthria or dysphagia, problems speaking and swallowing due to ALS. And so that's something that I will commonly use in clinical practice for my ALS patients who have bulbar onset disease. Other than that, I'm currently treating them with other ALS medications because we've seen that those have benefit in clinical trials. So using riluzole, radicava, and Relyvrio. I don't know of any trials that are only enrolling bulbar onset patients, although that it certainly may exist.
Okay, thank you.
Thank you for that. Let's see, I lost my place here. Okay, so could you share if there are any ATX and ASO clinical trials that are currently
Yeah, absolutely. So Biogen has a trial that's targeting ataxin-2. The medication
I still don't know much. They think penetrance is 60 to 90%.
Sorry, I lost
Go
that.
ahead. No, don't worry. Keep going.
Oh, okay. Yeah. So the company Biogen that actually makes Tofersen or Qalsody also has an ongoing clinical trial for ataxin-2 gene mutations. Again, it's an ASO trial. That trial is unfortunately closed for enrollment of new patients, although there are patients who are being actively treated right now. One of the interesting things in that trial is that they included both patients who have the ataxin-2 repeat expansion, as well as people who actually had sporadic ALS, because it's thought that the ataxin-2 protein may interact with TDP-43, and it could have benefits, or changing the function of ataxin-2 could have benefits even in people who have sporadic disease. And so we'll have to look out for the results of that trial. And I don't know the exact date when we're expecting data for that.
Thank you.
Thank you, Dr. Garret. So can the ALS genes express later in life and not be positive at early ages?
It's a great question. So what I would say is that, when people who have these ALS gene mutations, the gene is there from, the time you're conceived, actually. And so it doesn't suddenly switch on. Why, someone can live with some of these ALS gene mutations for 50, 60, even 70 years, and then all of a sudden develop a rapidly progressive disease, is something I think we're still really trying to understand. It may be that, again, you're, accumulating, we'll say, SOD1 protein that is aggregated and it's causing disease, relatively, or basically is aggregating and causing some degree of toxicity, but there just reaches a critical tipping point that kind of the disease accelerates from a certain, once you hit a certain threshold of damage, is what I would say. It also could be that, again, there are other environmental factors, for example, that kind of influence and impact when this disease strikes.
Yes, thank you.
Dr. Garret, in light of the recent approvals of CRISPR gene therapy and sickle cell, why aren't we seeing more focus on CRISPR and ALS?
Yeah, so I think there definitely are people who are kind of trying to use CRISPR technologies. That was kind of where I was getting at a little bit with the gene editing. Now, one of the challenges in using, say, CRISPR technologies to treat neurologic diseases is actually, the biggest challenge is not necessarily the CRISPR technology itself. I think one of the biggest challenges is how do you get the kind of CRISPR cassette with the genetic information into all the different cells of the brain and spinal cord that it needs to go without causing toxicity. And so usually this is involved kind of inserting that genetic information into kind of a viral vector that can then transfect the cells. And I think a lot of the challenges have kind of revolved around kind of that piece of the puzzle. And so I think that breakthroughs that we're seeing for CRISPR technology in other disease states are likely to kind of affect ALS as well in the future. So it's coming. It's just a little bit harder to do than the ASOs. There's also the aspect that changes due to a gene therapy would be kind of irreversible. And so it's nice that with an ASO, they have a limited time of effectiveness. And so if someone develops toxicity, you can stop giving them the drug. That wouldn't be possible with CRISPR.
Thank you, Dr. Garret. So this is really, one of the big takeaways tonight is, and has been in the science, is identifying signs and symptoms earlier. So in terms of artificial intelligence, helping identify the signs and symptoms that are earlier, what is there in terms of AI? And if so, is there anything currently commercially available?
Yeah, I have to say it's not something that I know extremely well. So I know there's been work looking at, using AI to say, look at people's Google searches and try to see, if someone is Googling, muscle twitching or, weakness or foot drop, could you, direct someone like that to an ALS clinic? That's certainly a possible use. The other situation where I find that, it theoretically could be very useful would be, it turns out, one of the challenges in ALS is many physicians aren't familiar with ALS, and ALS is not the first thing to think about when someone presents with hand weakness or foot weakness. And so I think AI as a tool to kind of help, say primary care physicians or orthopedists when they're evaluating new patients, maybe AI can prompt them to, consider ALS as a diagnostic possibility.
Thank you.
Thank you for that. Dr. Garret, what did the line colors indicate in the left graph? It was a couple slides back in your presentation before the ATLAS trial, SOD1 gene carrier slide. You had side-by-side graphs.
Let me just take a look and see what I was looking at.
It was the neurofilament, I believe.
The biomarker one. Yeah. Oh, sorry. That's
biomarker.
A great question. Yeah. So I didn't get into it because it wasn't too critical. Those were actually people with different types of gene mutations. So the most common one on that graph was the red color, which was the SOD1 individuals. There was one person in green who had a FUS gene mutation. And there was a gentler slope in blue, which is someone with the C9orf72 gene. And so one of the difficulties in interpreting neurofilament potentially pre-symptomatically is we could imagine that there are differences in what that rise looks like across people who have different gene mutations. The vast majority of the data so far has been from people who have SOD1, who have rapidly progressive SOD1 gene mutations. Some of the data that's come out of, say, the ALL-FTD study has shown actually that people with C9orf72 may have kind of a gentler rise over a longer period of time compared to the pretty rapid rise over 6 to 12 months that we see in SOD1.
Okay, thank you for that.
Mm-hmm.
Thank you, Dr. Garret. We have another question regarding the UNC13A. Can one test?
Yeah, so there's a couple different things. So one is that there is, so on many of the free genetic panels that exist that we order from clinic through, say, Prevention Genetics or Invitae, the UNC13A gene is actually on that panel. However, it doesn't typically report out the relatively common risk polymorphism that I was talking about. I have seen that sometimes actually through things like actually commercial genetic testing that things like 23andMe, that people can actually have ways to access genome sequencing. It does oftentimes, there are some trials that will do genome sequencing to kind of identify these sorts of risk polymorphisms in the context of a trial, although I don't know that that's always kind of reported back to individuals. So I think you would really need sequencing data.
Okay, thank you.
Thank you, Dr. Garret. And there seems, you addressed this a little bit before when we were talking about ASOs and TDP43 as well, but how long do you think until ASOs are targeting TDP43s directly, or what's the likelihood that more programs are in that space?
I think, again, the real challenge is that you can't kind of just decrease the level of TDP-43 to a large degree, because it has the potential to upset regulation of hundreds of different genes. I think there's more potential for people who have, gene mutations in TDP-43 that cause disease, that you could kind of more specifically target that specific mutation. But I have to say, I haven't done extensive work in that space, so there may be other people who could answer that.
Are those misfoldings considered individual mutations? Because there seems to be many different misfoldings of TDP-43.
So TDP-43 is kind of like misfolded and aggregated across 98% of people who have ALS. And so I think the question is, is there a specific genetic change in TDP-43 that causes these? That may be an easier kind of target with an ASO.
Got it. Thank you.
Thank you, Dr. Garret. And so there's been a lot in the ALS community about nutrition. And so we have a question about, in terms of recommendation for nutritional supplements that might help prevent or even delay the onset of ALS. What have you observed, and any recommendations?
Sure, absolutely. So first of all, what I will say is I think that this is always kind of best addressed in conjunction with someone's treating neurologist if they have, ALS. I also think that there can be a difference between what may be good for ALS patients versus what could help prevent disease in an ALS gene carrier. So one of the interesting papers that I was reading about was some work by Jay Lee at Columbia University that was talking about impact of diet, looking specifically at like glycemic index, and showing essentially that people who had foods that were kind of high in glycemic index, so things like bread, potatoes, actually seem to experience slower disease progression. Now, I think there's still a ways to go to show that is that is truly a causative thing, that is the dietary change that causes someone to have a slower disease progression. But that certainly is promising. Ordinarily in clinic, I will recommend essentially that patients make sure that they're not losing weight. We know that ALS is a hypermetabolic state, so people burn more calories and have to eat more. We know that losing weight is associated with more rapid disease progression. The other thing that, in terms of supplements that I will often use personally, is the high-dose methylcobalamin injections, kind of 50 milligrams twice per week. And the reason for that is there was a phase 3 clinical trial that was done in Japan that showed benefit in slowing down progression of disease for people early on in their disease course. So that's the primary one that I usually recommend. ALS Untangled, as I'm sure many have seen, is a really great resource if you're interested in nutritional supplements. But again, it really needs to be considered in the context of your medical history too.
Excellent. Thank you.
Thank you, Dr. Garret. So as part of prevention or reduction of penetrance of ALS, has light therapy or location closer to the equator been evaluated?
I don't believe so. The incidence of ALS generally is pretty consistent across the globe. There's some minor differences, but it's actually relatively similar. So the disease that really has a strong effect of your latitude is really multiple sclerosis, and I don't believe we've seen anything like that in ALS.
Thank you.
And we have one last one, Dr. Garret, I think. So thank you for mentioning both ALS and FTD. It feels like FTD is often not recognized, or felt like it's not recognized as much by generally the practicing neurologists as a symptom of ALS. Would like to get your thoughts on that, because it definitely is something that's concerning to a lot of people with ALS.
Yeah, I think it's concerning to ALS patients who are worried about whether they might develop that in the future, and I think it's upsetting to their friends and family who sometimes struggle with those symptoms. I think people's cognition affects their sense of self to a really great degree. I think one of the important things is that people should feel comfortable expressing concerns about changes in behavior, disinhibition, changes in memory and thinking to their treating physicians, so that we kind of have that information and can evaluate it. There are many kind of relatively quick to administer cognitive scales that can be done in the ALS population to screen for FTD. It's hard because, as we all know, multidisciplinary ALS clinics are very busy, and so I think it's hard to add on additional testing at points. Really, as part of this all ALS study that we're launching, we're trying to work much more closely with the frontotemporal dementia kind of researchers at all FTD to make sure we really are paying attention to it, because it is a really big problem.
Wonderful. Thank you.
Dr. Garret, we've got one last question for you also, or potentially, but I think we're almost there. You mentioned head traumas and military service increases risk of ALS.
Yeah.
Are acquired head and spine injuries significantly related to earlier onset or just onset of ALS? Or if so, what preventative measures can be implemented by this population?
Yeah, that's a great question. So I have to say, I don't recall off the top of my head kind of an effect of age of onset just on the increased, or just the increased risk. We don't quite know why the military population in particular has a higher incidence of ALS. There's lots of theories about it. Certainly increased incidence of kind of concussive forces from artillery or from rifles may play a role. People have kind of wondered about different toxic exposures as well. I think it's still to be answered, and it's part of the reason why we need lots of good observational studies to kind of teach us more about this disease.
As a quick follow-up, are there any polygenic studies that are kind of doing cross-sectional work with military, or any genetic studies that you know of?
So what I'll say is that most of these studies, at least are, so I'll give a plug to the kind of CDC's kind of ALS registry that they have. They do really good epidemiologic work that is trying to look at a lot of these different risk factors. Most of these studies, include detailed questions about military service as well. And so our hope is that over time, we'll get more information. I think it just requires a lot of data and a lot of patience to really establish kind of these risks.
Thank you. Thank you so much.
We had a great session, and thank you for spending an hour with us. And we really appreciate you answering all the questions. And we will let you, we thank you, and we let you have your evening back, Mark.
Perfect. Well, thank you all so much.
Thank
It was
you.
great to be here.
Thank you.
Thank you. What a pleasure.
Outstanding.
Folks, once again, look what came to your living room. I mean, I want to point this out, though. Kathy Shea, you are one of the happiest people that I've seen on our program. And you came with your crown on tonight. I mean, you got chi, girl. Thank you so much just for being so brave to be yourself. And folks, that's what we need to do. This disease, we feel like it takes something away from us, and it does. But it also adds something to us, because it shows what kind of person we are when we're under fire. My family, it's the time of day when I want to say each one of you are so special. So folks, until we meet again, let's all say goodnight. On 3. 1, 2, 3.
Good
Good
night.
night.
Good night, you all.
Good to see you, Dr. Eddie and Katie Shea, my girl. You are awesome. Thank you so much for sharing yourself
Have
with
a
us.
good night.
Have a good
All
night.
right. Good night.
Thank you.